Tetralogy of Fallot, same disclosures as earlier. So Tetralogy of Fallot is a malformation that was first described in the 1600s by a Danish monk, Nicholas Steno, in an ectopic heart from a fetus. And that's actually a common association with Ectopia cordis with Tetralogy of Fallot. And it was until the 1800s, the late 1800s, when Dr. Fallot described actually the malformation with the 4 features that is known today, and has been also described as the maladie bleue, which is in French meaning the blue disease, because babies would turn blue once their pulmonary pressure goes up after a period of time, and also because of the myocardial hypertrophy, especially right ventricular hypertrophy. The heart on X-ray takes the shape of a sabot, which is a French shoe, as you see on the slide here. So the features of the malformation is a subaortic malaligned ventricular septal defect, as you see here, malaligned with the atrial septum, an overriding aortic root that commonly appears dilated in the 3rd trimester, a narrow stenotic pulmonary artery, which is a hallmark of the feature itself, and typically the stenosis is subinfundibular here. And the 4th feature makes the tetralogy is right ventricular hypertrophy, which is classically not present in the fetus. It's important to note that Tetralogy of Fallot is more of a spectrum of malformations, and that based on the level of obstruction of the right ventricular outflow tract. So you can go from almost a normal appearing pulmonary artery with an overriding aorta and a VSD, with the classic form, which is associated with pulmonary stenosis, and then on the other extreme of the spectrum is the pulmonary atresia with all the associated abnormalities. It is a fairly common abnormality, so it is one of the most common abnormalities we see on prenatal ultrasound. There's a male to female ratio is about 1, unlike left-sided lesions, which are more common in male fetuses and newborns. There are 3 main forms. The classic form, which is related to the presence of the pulmonary stenosis, is present in about 80% of cases. The pulmonary atresia with VSD is the name applied when there is pulmonary atresia in association with aortic override. That's in probably the remainder of the lesions, and very rarely you will encounter the absent pulmonary valve syndrome. It's quite a rare malformation. I think if I go back 10 years, we have seen 2 or 3 in our unit, a very busy unit with a lot of cardiac malformations. And there are other forms that also are associations with different diseases, and I'll show you some examples of that. Let me take a brief moment to review the normal anatomy of the left ventricular outflow tract because of its importance in at least suspecting the diagnosis of Tetralogy of Fallot. So I mentioned this briefly. So the blood that enters the mitral valve exits from the aorta with the direction towards the right shoulder of the fetus, and the blood that enters the tricuspid valve exits from the pulmonary artery with the direction of blood flow towards the left shoulder. So you could see at the level of origin of the great vessels, the direction of blood flow is perpendicular to each other, as you see here. As I mentioned yesterday, these vessels become more parallel as they ascend further into the chest. So that's an important feature for you to understand about the relationship of the great vessels as they originate from the heart. The first important feature of the LVOT is that in the normal fetus, the LVOT makes a slight angle with the ventricular septum as it ascends from the aorta. And you see it here on color Doppler with radiant flow, and here on grayscale. And again, here's a normal fetus, and you can see the LVOT has this nice angle that it makes with the ascending aorta. This angle is lost in the presence of aortic override, as you see right here. So that's an important feature to look for as a screening feature. As you look at the LVOT, always try to see that angle that it makes as it comes out of the left ventricle. Here's another example of aortic override. And you see how the vessel comes straight out in parallel to the septum itself. The second important feature, that the ascending aorta should have no blood flow coming from the right ventricle into it, right? Because it's coming from the left ventricle. The presence of right ventricular blood into the ascending aorta is characteristic of aortic override, but also you could see it in a perimembranous ventricular septal defect, as you see right here. Typically, you see the aliasing related to the velocity of flow across the defects, either here or the accelerated amount of blood coming out in the aorta gives you that aliasing view in the overriding aorta. So in tetralogy of Fallot, at the level of the four-chamber view, typically the four-chamber view is normal, with the exception of occasional left axis deviation. And that's why it's important to assess the cardiac axis, as we've discussed yesterday. So if you look at this four-chamber view, can you see what's the abnormality here? A slight left axis deviation maybe, but also remember what I told you to look at the descending aorta, and that descending aorta is on the right side, right? So that is highly suspicious of a right-sided aortic arch. With some cardiac deviation, then you're thinking, is this a truncus or is this a tetralogy of Fallot? And that's really some important features there. Here's another case with tetralogy of Fallot, left-sided aorta here, but look at the angle that this heart makes with the cardiac axis. We looked at our data looking at the cardiac axis, and this is Dr. Zhao, who now works with Shab. Here's one of his work, looking what's the differentiating features of tetralogy of Fallot that has cardiac axis deviation versus those that didn't. And what we found is those that have a cardiac axis deviation tend to have more proportions of pulmonary atresia, more right-sided aortic arch, and had a worse outcome than those that had a normal axis. So I think part of the axis could be related to these associated abnormalities. Just keep that in mind. The five-chamber view is clearly abnormal, right? You have an aortic dextroposition, so you have an aortic override, and the aorta could be dilated in the third trimester, and by definition, you have a perimembranous subaortic VSD. And here you see an aortic override. Again, look at the angle that this aorta makes with the ventricular septum, and this is an axial plane showing you an aortic override between the right and the left ventricle. Color Doppler is really helpful in this location because it gives you this confirmation that the blood comes from the right and the left ventricle. And the most optimal view is the apical view to look at that, as you see right here and you see right here also. This has been described in the literature as the Y sign, the blood coming from the right and the left ventricle into the ascending aorta. Again, it's characteristic of aortic override, sometimes seen in double outlet ventricles also, but that is important. And here's a 3D rendering of another fetus with the tetralogy of Fallot showing you the aortic override. This Y sign is critically important in the first trimester because that is our clue to the presence of aortic override in the first trimester. I don't think you can clearly see on grayscale an aortic override unless you're like in real optimal imaging. But classically, color Doppler will show you this aortic override. This is just a still image from this clip, and that should be the clue for the presence of abnormalities. Also note the cardiac axis in this fetus. Look, it's almost 90 degrees. That's another feature of the presence of cardiac abnormalities. Studies that looked at the Y sign in the first trimester have shown a very high correlation with the diagnosis of aortic dextroposition. So it's really an important feature to keep in mind. So what about the RVOT? So by definition, the RVOT is abnormal, right? There is infundibular pulmonary stenosis. So typical pulmonary stenosis is below the valve, but also could be valvular. There's associated valvular stenosis also. And there's a spectrum from pulmonary stenosis to pulmonary atresia. It's always important also to look at the origin of the branch pulmonary arteries, so you can maybe diagnose a hemitruncus or something like that related to these lesions, and I'll show you an example of that. So here's your classic RVOT view here, and you see look at the size of the aorta in relationship to this pulmonary artery. Remember, the pulmonary artery should be slightly larger than the aorta, and look at the size differential here. Clearly, the aorta is much smaller, and if you look on this view right here. Here's the pulmonary artery coming out. See the division of the pulmonary artery, cross-section of the aorta, and you see that tissue here that is causing the infundibular stenosis. As part of the embryogenesis of tetralogy of Fallot, that is pushed into the RVOT outflow, resulting in the obstruction. And here's another example showing you a cross-section of the aorta, and look at the size of this pulmonary artery and this infundibular tissue right here that is obstructing the outflow tract. So we talked about the importance of the overriding aorta on color Doppler or the 5-chamber view. I think the RVOT will show you the pulmonary stenosis in relationship to the aorta that is diagnostic then of tetralogy of Fallot, this combination. When you look at the 3-vessel trachea view, and Michelle had showed you very nice images of abnormalities in the 3-vessel trachea view. Here you see a dilated aorta. Remember that there's an association in tetralogy of Fallot with right-sided aortic arch in about a quarter of cases. So you need to make sure where the aorta is, on the right or the left. By definition, you should have a small pulmonary artery. But the importance of the 3-vessel trachea view also, it allows you to assess the direction of blood flow. So the blood flow is going forward. That's probably a good prognosis type of tetralogy. If the blood flow is going in reverse direction, the pulmonary artery, there has a worse prognosis looking into the postnatal outcome. Again, here's the 5-chamber view, looking at the overriding aorta, and look at the size of this pulmonary artery at the 3-vessel view in relationship to the aorta. Here's the superior vena cava, clearly small. Color Doppler and still images showing you the 3-vessel trachea view with the pulmonary artery much smaller than the aorta. Again, the pulmonary artery much smaller than the aorta here. 5-chamber view with the aortic overrides and the 3-vessel trachea view showing you the size of the pulmonary artery in relationship to the aorta. So why did I put this image here? Because an important observation prenatally is that the 3-vessel trachea view, when you have pulmonary stenosis, the pulmonary artery appears like a branch of the aorta. That is not really the case, but that's how it looks. And I put this to give you like a memory burn of this view right here. So anytime you see the pulmonary artery arising like a branch of the aorta, that is significant pulmonary stenosis. And just keep that in mind. Here's another example of a normal 3-vessel trachea view. Look at the size of this pulmonary artery, and here's a fetus with tetralogy of Fallot. And 3D rendering, look at the size of the pulmonary artery in relationship to this aorta here. So when you look at the common cardiac and extracardiac abnormalities with tetralogy of Fallot, right-sided aortic arch in 25% of cases, persistent left superior vena cava is also an important association. Keep that in mind. And look at chromosomal abnormalities in 30%. And don't forget about the 22q11 deletion in a significant proportion of those fetuses. Risk factors for 22q11 deletion is the presence of a right-sided aortic arch, if the thymus appears hypoplastic, small or absent, any extracardiac abnormalities with tetralogy of Fallot substantially increases the risk of the George syndrome and the presence of polyhydramnios in those lesions. There are other associated cardiac anomalies with tetralogy. I mentioned the association when I gave the talk on the AVSD, atrioventricular canal defect, with tetralogy, but that's a rare association. Abnormal coronary circulation, which becomes important in managing those patients postnatally, and then rarely you have anomalous pulmonary venous return. Some of the poor prognostic factors in follow-up of those patients: deceleration in the size of the pulmonary artery, the aorta being larger, cessation of forward flow in the pulmonary artery on color Doppler, reverse flow in the ductus arteriosus, which you could see before you start seeing reverse flow in the pulmonary artery itself, tetralogy of Fallot with pulmonary atresia, absent pulmonary valve syndrome, associated chromosomal and extracardiac abnormalities, and a small left ventricle, and any venous abnormalities that could exist. So if you look at tetralogy of Fallot, it's actually a syndrome. The classic form is the pulmonary stenosis with forward flow in the pulmonary artery that you can clearly see on the 3-vessel trachea view, reverse flow in the pulmonary artery. Pulmonary atresia with VSD is the other subform, the severe form. Absent pulmonary valve syndrome is classified as part of tetralogy of Fallot. And then you start looking at the right-sided aortic arch, AVSD, and others. Let me show you a series of cases to highlight all these features. So let's look at this case. This is the 5-chamber view. I think you should all recognize that this is an aortic override, right? So here's the aorta coming out, right ventricle, left ventricle, loss of the angle, clear aliasing here, classic aortic override. Here's the pulmonary artery. So here's the pulmonary artery coming out. Here's the aorta. Is there pulmonary stenosis here? Is the pulmonary artery normal in size? What do you think? No, should not. It should be at least equal, if not larger than the aorta. Clearly, the pulmonary artery is small. So what do you do next is the 3-vessel trachea view. And here it doesn't look bad, actually, and there's forward flow. So this is your classic tetralogy of Fallot with forward flow in the pulmonary artery. Prognosis is typically good for this fetus. Here's another case. Aortic override. Yeah? Next is the 3-vessel trachea view in grayscale. Here's the pulmonary artery, and here's the aorta. So what do you think here? Very small pulmonary artery, right? Looks like a branch coming out from the aorta. We put color Doppler, and there's reverse flow at the level of the 3-vessel trachea view. So this is a tetralogy of Fallot with pulmonary stenosis, reverse flow in the pulmonary artery. This fetus is going to be much sicker than the previous fetus, right? Because there's this, when the ductus closes after birth, this baby is going to be in serious trouble. And remember what we talked about, the branching of the pulmonary artery in those cases. All right, so what do you see right here? 4-chamber view or 5-chamber view. Descending aorta appears a bit dilated, right? Look at the cardiac access in here, significantly abnormal. Aortic override in here. Then I'm looking at the 3-vessel view, and here's the pulmonary artery coming out. Look at the size of these branch pulmonary arteries here. And look at the size of the aorta. So what are you thinking here? Pulmonary arteries coming out from the right ventricle is very, very small. That's highly suggestive of pulmonary atresia. Okay, then what is the association of pulmonary atresia with VSD? The presence of these MAPCAs, which are the major aortopulmonary collateral arteries. So the blood flow to the lungs is actually coming from the systemic circulation, and you can see this either on a sagittal or coronal view of the descending aorta, and you see the branching going into the lungs. And you see the schematic drawings right here. So this is a very serious malformation, right? It's a much more associated with worse prognosis than your classic tetralogy of Fallot feature. Here are other fetuses on 3D rendering showing you the origin of these MAPCAs coming out from the aorta. Here, and this is on cross-section showing you going to the lungs. All right, case number 4. What do you see right here? Aortic override? Yes? So what do you want to do next? Look at the RVOT. Here's the RVOT on grayscale. So what do you see right here? See the division of the pulmonary artery much smaller than the aorta. So you are thinking that this is a tetralogy of Fallot type, correct? There's aortic override and pulmonary stenosis. Then you look at the 3-vessel trachea view, and I'm going to tell you that this is the trachea in the middle, just the baby swallowing, so you see a little bit of fluid coming in and out. You have a right-sided aortic arch, right? And you have a hypoplastic ductus arteriosus. Okay? So this is a tetralogy of Fallot with pulmonary stenosis, right-sided aortic arch, and hypoplastic ductus. And that's how you work your sequence through the evaluation of these fetuses following the 4-chamber view, 5-chamber view, RVOT, and the 3-vessel trachea view. Here's another case. Aortic override, yeah? Here's the 3-vessel trachea view, or 3-vessel view. So what do you see here? Here's the trachea right here. Right-sided aortic arch, correct? Clearly. Small pulmonary artery, here's the azygous vein coming into the SVC. And then if you look for the ductus here, you won't find the ductus. So this is a case of tetralogy of Fallot with pulmonary stenosis, right-sided aortic arch, and absent ductus arteriosus. How about this case here? What is this right here? I'm showing you just some features of that. That's the brachiocephalic vein that is under the aorta. So this is a retroaortic left brachiocephalic vein, again with absent ductus and tetralogy of Fallot. How about this case here? Aortic override. So let's look at the pulmonary artery now in the three-vessel view. So here's the pulmonary artery coming out. Look at the size of these branches of the pulmonary artery. Okay, and if we add color Doppler, look at the incompetence of the pulmonary valve here, with the blood flow going in and out. These are classic features of absent pulmonary valve syndrome. So unlike the other tetralogy of Fallot's, where the pulmonary artery would look really small and stenosed, here the branch pulmonary arteries would look really large. And this view right here should be a classic view for you at the three-vessel view for the presence of absent pulmonary valve syndrome. That's really easy to make the diagnosis once you see what you expect to see in the syndrome, and then color Doppler will clearly show you the level of regurgitation back and forth into the pulmonary valve. And here are the features that you should see: overriding aorta, large branch pulmonary arteries, and significant pulmonary regurgitation, as you see here. So in looking at tetralogy of Fallot, between the different features, the tetralogy of Fallot with pulmonary stenosis, pulmonary atresia, and absent pulmonary valve syndrome, the pulmonary artery is narrow here, but very narrow in pulmonary atresia. You cannot see really flow through that, and markedly dilated in absent pulmonary valve syndrome. And the presence of MAPCAs are classic for pulmonary atresia with VSD, about 20% or more of the cases. And 22q deletion is common in the three of them, probably more common in the absent pulmonary valve syndrome. So the absent pulmonary valve syndrome is a more severe form of tetralogy of Fallot. This is a fairly recent study looking at about significant number, I don't remember the number of cases, but a combination of tetralogy with absent pulmonary valve syndrome and some absent pulmonary valve syndrome with intact septum. You could see that survival to birth was 50% and 44% in those respective lesions, and survival of subjects born alive beyond neonatal period was 84% in tetralogy of Fallot with absent pulmonary valve syndrome, and 100% those with intact ventricular septum. So the messaging here is that this is a more severe form of the classic tetralogy of Fallot that you clearly see in your office on a day-to-day basis. I want to finish just with this case. This is an overriding aorta on grayscale and color Doppler, and here's the pulmonary artery, and you see the pulmonary artery looks almost normal here. So again, this is the other side of the spectrum where the pulmonary artery could be nearly normal, and this is just a subaortic, it's just a VSD that's probably an aortic override that's causing that. So keep in mind that there's a significant spectrum of malformations here from one side to the other. This is in your syllabus about the outcomes. I will just highlight the association with right aortic arch in this series. This is a large meta-analysis from the literature, and the associations with 22q and the various lesions of tetralogy of Fallot. Okay, so let's do this diagram to see how you can arrive to the diagnosis. Your suspicion is based on the presence of a VSD with an overriding great artery. So what you want to do next is look at the pulmonary artery. Where is the pulmonary artery coming from? If the pulmonary artery is coming from the right ventricle, what do you want to do next? You want to assess the size of the pulmonary artery. If the pulmonary artery is normal, this is probably just a malaligned VSD. If the pulmonary artery is small or moderate, this is your classic tetralogy of Fallot. And if the pulmonary artery is very small, then this is your pulmonary atresia with VSD. If the pulmonary artery is very large, then this is absent pulmonary valve syndrome. Remember, there's an association with an overriding aorta here, or overriding great vessel, actually. If you don't see the pulmonary artery, think that this probably is a pulmonary atresia with VSD, because the pulmonary artery is really very small and difficult to see. If the pulmonary artery arises from this overriding great artery, then you are dealing with a common arterial trunk. And that's your differential features of how you work up a fetus with an overriding great artery, how you work up the diagnosis, going through the origin of the pulmonary artery, the size of the pulmonary artery, and then certainly you can refine this diagnosis with color Doppler, seeing there's forward flow or back flow in the pulmonary artery to decide the severity of that and so forth. And here, color Doppler is very helpful in looking for MAPCAs originating from the aorta in a sagittal or more commonly in a coronal view. All right, thank you for your attention. A complex lesion, but I think if you systematically go through it, you'll be able at least to make the basic diagnoses into that.